This lecture is about thyroid disorders, but specifically about hyperthyroid. I know that hypothyroidism is more common, but we're looking more at the acute presentation. On the front screen, look at patients that had radioactive iodine treatment before and after. They're pretty interesting, looking at those goiters after the iodine has been able to eradicate the tissue. So we do know as nurses that various thyroid disorders and diseases are prevalent. The thyroid functions regulated by thyroid stimulating hormone secreted from the anterior pituitary. Hyperthyroidism is an excess production or release of thyroid hormone and all the clinical manifestations that go along with it. The thyroid is the source of excess thyroid hormone versus looking at thyroid toxicosis, which referring to a syndrome produced by excess hormone regardless of its source. So what I'm talking about there is what's the difference between primary and secondary hyperthyroidism. And we know primary hyperthyroidism is independent of TSH, but secondary hyperthyroidism is TSH dependent. So you kind of have to put it in your mind about causation and is it primary or secondary. Most common cause of hyperthyroidism is Graves' disease, autoimmune condition. And one way to remember the severity of Graves is that it'll put your patient in the grave. Okay, so it's quite serious. Whenever you're considering hyperthyroidism as a diagnosis, and Graves particularly, you've got to be able to differentiate out transient thyroiditis, and that's done through lab and presentation. Look at the epidemiology, the female to male predominance, 7 to 1, and most common in women aged 20 to 40. And you know, these epidemiological facts are really important because they help you go to a diagnosis or formulate a really secure differential if you know the epidemiology behind disease and disorder. I thought it was interesting that 5 to 9% of postpartum thyroiditis is in pregnant women. 3.5% have occult papillary carcinoma. These are people with thyroid nodules. 50% are micronodules, 15% are palpable, 10% of the population has abnormal TSH, 5% of women either have overt hypo or hyperthyroidism. The pathogenesis is Graves' disease is an autoimmune disorder. And when the thyroid stimulating antibodies or the immunoglobulins compete with TSH for those TSH receptors on the thyroid gland, they activate the production of adenosine monophosphate. This increases the synthesis and release of the thyroid hormone. Subacute thyroiditis is considered a post-viral illness, and often a patient after an upper respiratory will come with an enlarged tender thyroid. Silent thyroiditis or painless is also considered to be autoimmune. So that would be, you know, that patient that comes in with a painless thyroid, but you can see that it's enlarged. Clinical presentation, really variable. The thyroid hormone affects all organs. So our author of our text did a good job on table 2141 to really describe the symptoms by organ. But the symptoms are secondary to the sympathetic activity and the increased catabolism that happens, okay? So another term that you might see is apathetic thyroidism, hyperthyroidism, and that's really somebody that's lacks symptoms. I like mnemonics because they help us remember. There is a no-specs mnemonic used to describe the eye changes related to hyperthyroidism, and any nurse practitioner that is astute should pick up on eye changes. Physical exam, all the things you would think, comprehensive exam. We really want to look at energy level, mental status, facial affect, the skin, the hair, cardiac and neuro assessment, and then patient voice could be a physical presentation, and inspect and palpate, auscultate that thyroid gland, listen for bruits, okay? And it's not hard to palpate thyroid gland. I learned how to palpate a thyroid gland on myself and my husband when I was in school. And I was not shy about it so that I would understand the anatomy and the procedure. And so I was ready when I started clinic. Diagnostics, TSH is absolutely the best screening test for primary hyperthyroidism. You can expect it to be low or undetectable. You also include a T3, T4, so you can assess the degree of the disease. TSH levels really remain decreased up to 3 months after treatment, so you got to follow with a free T4. And the table of 214-2 does a great job saying which labs are necessary for what type of hyperthyroidism. Of course, you're doing that initial screening. Abnormal liver function tests are seen in people with hyperthyroidism, so they're included. And then we really do scan, whether we do a nuclear scan or we do an ultrasound to look for multinodular goiter versus a solitary nodule. And we use some of that information to calculate how much radioactive iodine they need for treatment. And then just diagnostically, always remember to review any iodine-containing meds they might be ingesting. Differential diagnosis, look on 1143 and review those. But I was grossed out by that hamburger thyroid toxicosis, and it reminded me that we have to think out of the box. So if in your practice you see a lot of people coming in with thyroid toxicosis or thyroid disorder, think to yourself, what could be happening? What's the epidemiology behind this? In that case, read about that, where they ate beef with thyroid tissue in it, and they all had hamburger thyroid toxicosis. Management. It just really depends on the cause and the patient's age. The options are thyroidectomy. Pharmacotherapy includes beta blocker. You got to reduce their tremor for them and their heart rate. Thiamide therapy, and there's several thiamide drugs you can choose from, and it really the path to whether you're going to choose MMI or you're going to choose PTU really depends on the patient and their specific issues, age, comorbidities. Radioactive iodine. And we do specialist consultation for severe hyperthyroidism. I think we know that if they're gravely ill or near coma, they're going to the ER. We use endocrinologist, ophthalmologist for all patients that have the eye involvement. PCP can definitely, we can manage, we can diagnose, we can order labs, order radioactive iodine and treatment with meds, but really you have to feel comfortable. And I generally refer most people with hyperthyroidism, although I do the screening labs, and I might even initiate the oral therapy. Graves' disease management, again, beta blockers, MMI, Tapazole, PTU. PTU is not the first choice related to liver failure. After 6 months, about 30% of the patients remit. Radioactive iodine is the treatment of choice in people over 20 or failed oral therapy. Medical therapy for those under 20, pregnant women, or those who have a high likelihood of remission, and that's determined on mild disease, small goiters, and active Graves' orbitopathy. Okay, so we've got active, and we've got to get that in remission so we can offer more definitive treatment. Baseline blood count and LFTs before any therapy starts. All I really want you to know is that there is subclinical hyperthyroidism and there is thyroiditis. Subclinical is suppressed TSH, but normal T3, T4, and so that treatment's based on the patient. And thyroiditis may be subacute or painless, and I mentioned that earlier. Referrals, you can start the initial care in primary care. You just about have to because there's a delay in getting them to see an endocrinologist. We don't have enough. Refer for Graves' disease if not experienced using those oral meds. Pregnant women need to be referred, and then most of us primary care nurse practitioners do refer for radioactive iodine. Patient and family education, you've got to educate them about the signs and symptoms of hyperthyroidism and the danger of the thyroid storm. Need to educate them about beta blocker use and side effect of bradycardia, increased depression rates, the rare side effect of the oral meds, and they have to, so if they show up with signs and symptoms of infection, and we have to rule out that that's not what's happening. And then we got to caution about the use of radioactive iodine and pregnancy, and it's after treatment also. There's certain time spans. It's quite important for them to know this. Thank you.